I'm Dr. Jonathan Salo. I'm a GI cancer surgeon in Charlotte, North Carolina. If you're seeing this video, chances are you or someone close to you has had an encounter with esophageal cancer. These videos are designed to educate you about cancer and its treatment and help you and your cancer team make the right decision for you. Of course, there's no substitute for the expert opinion of your cancer care team. The topic of this video is locally advanced squamous cell carcinoma of the esophagus. The treatment recommended will depend upon the stage of the cancer. If you haven't already, this may be a good time to review the video on diagnosis and staging. A PET or CT scan is used for staging. If the scans show that the tumor is localized without signs of spread beyond the nearby lymph nodes, it is considered M0. On the other hand, if the scans show signs of spread, this is considered metastatic disease or M1. Patients with metastatic disease are best treated with chemotherapy or immunotherapy and are generally not treated with surgery. We will focus in this video on locally advanced cancers. Locally advanced cancers are T2 or T3 or node positive. In addition, locally advanced cancers are M0 and have not spread to the liver, lungs, or bone. If this terminology is not familiar to you, please refer to our video on diagnosis and staging. To make things a bit more complicated, there are two different types of esophageal cancer, adenocarcinoma and squamous cell carcinoma. The treatment of these cancers is somewhat similar, but different enough that we've prepared a different video to talk about adenocarcinoma. This video will focus on locally advanced squamous cell carcinoma. I'm occasionally asked by patients why we don't just remove esophageal cancer with surgery as the first treatment. The answer is a bit complex. When a patient is diagnosed with cancer of the esophagus, it can look like the cancer is confined to the esophagus. But sometimes what we see from the inside of the esophagus is just the tip of the iceberg. There's frequently spread of cancer cells into the nearby tissue or lymph nodes. If surgery is performed as the only therapy for locally advanced cancer, there's a risk that cancer cells can be left behind. Preoperative therapy is administered before surgery and is designed to shrink the tumor and kill cancer cells in the surrounding area. This typically involves both chemotherapy and radiation therapy. The overall goal is to shrink the tumor and kill nearby cancer cells to make surgery more effective. After preoperative therapy has shrunk the tumor and other cancer cells, surgery can be performed. Preoperative therapy combined with surgery offers the best chance to remove all the cancer without leaving any behind. For squamous cell carcinoma, chemotherapy and radiation are administered at the same time before surgery. Chemotherapy is given intravenously once per week, and radiation is given 5 days per week. Both are administered together for 5.5 weeks. This is also known as the cross treatment regimen. The chemotherapy is low dose, designed to make the radiation more effective. The therapy is generally well tolerated. Hair loss is uncommon, and low blood counts are also uncommon, and perhaps occur in 7% of cases. The radiation can, however, cause an inflammation in the esophagus called radiation esophagitis. This can make eating more uncomfortable, particularly during the last 2 weeks of radiation. The good news is that this is temporary and usually resolves within 2 to 3 weeks after the radiation is completed. What this may mean, however, is that placement of a temporary feeding tube may be needed. The feeding tube can usually be removed 2 to 3 weeks after the end of radiation as the cancer shrinks and the inflammation subsides. To summarize, this approach to preoperative therapy uses 6 weeks of chemotherapy and radiation together. Surgery is typically performed 6 to 8 weeks after the end of radiation, as soon as patients are recovered. After surgery, the pathologist examines the cancer that has been removed. One of the things the pathologist looks for is how well the preoperative chemotherapy and radiation killed the cancer before the surgery. In some cases, the pathologist doesn't find any cancer that looks alive. In the other cases, the pathologist finds persistent cancer, which was not killed by the chemotherapy and radiation, but was removed by surgery. In about half the cases of patients treated with chemotherapy and radiation, followed by surgery, the pathologist does not find any evidence of live cancer cells in the specimen. In these cases, the cancer was probably cured by the chemotherapy and radiation alone. So patients with squamous cell carcinoma of the esophagus are cured by chemotherapy and radiation alone in about half of cases. The problem is, it can be hard to know for certain who is cured immediately after chemotherapy and radiation are finished. This makes the decision-making about what to do after chemotherapy and radiation a bit more complicated. The first step is to repeat the upper endoscopy and the scans after the completion of chemotherapy and radiation to look for evidence of persistent cancer that wasn't killed by the therapy. These tests will result in one of two answers. Either there's no visible cancer found, or persistent cancer is found either by endoscopy or on scans. In most cases, about 80%, no visible cancer is found, and in 20%, there's evidence of persistent cancer. Patients with persistent disease after chemotherapy and radiation are often candidates for surgery. Among patients with no evidence of cancer after chemotherapy and radiation, some are cured, but some simply have hidden cancer that will eventually grow back over time. Those patients who initially have no visible cancer, in whom the cancer then later regrows, are candidates for surgery. So how can we figure out which patients without visible cancer have hidden cancer that might regrow in time? We have a strategy called active surveillance. Patients who have no visible cancer after chemotherapy and radiation have an endoscopy every 3 to 4 months for the next 2 years, as long as no evidence of recurrence is found. If recurrent cancer is found, surgery can be done at that point. I know this sounds all rather complex, but the starting point is to get prepared for chemotherapy and radiation. There are 3 important ways. The first is to make sure you have enough protein in your diet. We have a video on nutrition during your cancer therapy. Second is to stay active. We recommend 30 minutes each day of vigorous exercise, such as brisk walking. Third is to be careful about your dental hygiene. If you need any dental work done, check with your dentist. Keeping your teeth healthy can reduce the risk of infection during therapy. In some cases, a feeding tube may be necessary in order to maintain adequate nutrition. A central venous port may be needed to help with the administration of chemotherapy. We hope you found this video helpful. Feel free to leave a comment or questions, or if you have any suggestions for future videos. If you or a family member have had an encounter with esophageal cancer, I'd love to hear about your experiences, so please take a minute and leave a comment below. We're constantly creating new videos, so please subscribe to be notified of new videos as we post them.